Management priorities are: 1. Stabilize the patient, protect airway, restore circulation. 2. Identify the source of bleeding. 3. Definitive treatment of the cause, resuscitation and initial management, protect airway, position the patient on side. 4. Access, use 1-2 large bore cannula, take blood for HB, PCV, PT in cross-match, restore the circulation. If patient is hemodynamically stable, give NS infusion. If not, give colloid 500 ml/1 hour and then crystalloid and continue until blood is available. Transfuse blood for obvious massive blood loss, hematocrit less than 25% with active bleeding, symptoms due to low hematocrit and hemoglobin. Platelet transfusion should be offered to patients who are actively bleeding and have a platelet count of less than 50,000. Fresh frozen plasma should be used for patients who either have a fibrinogen level of less than 1 gram per liter or INR greater than 1.5 times normal. Overtransfusion may be as damaging as undertransfusion. Monitor urine output. Watch for signs of fluid overload, raised JVP, pulmonary edema, peripheral edema. Commence intravenous PPI, omeprazole 80 mg intravenous followed by 8 mg/hour for 72 hours. Keep the patient nil by mouth for the endoscopy. Treatment of variceal bleeding. Terlipressin. Treatment should be stopped after definitive homeostasis has been achieved, or after 5 days, unless there is another indication for its use. Prophylactic antibiotic therapy. Balloon tamponade should be considered as a temporary salvage treatment for uncontrolled variceal hemorrhage. 1. Esophageal versus band ligation. Stent insertion is effective for selected patients. Transjugular intrahepatic portosystemic shunts, TIPS, should be considered if bleeding from esophageal varices is not controlled by band ligation. 2. Gastric varices. Endoscopic injection of N-butyl-2-cyanoacrylate should be used. TIPS should be offered if bleeding from gastric varices is not controlled by endoscopic injection of N-butyl-2-cyanoacrylate. Treatment of non-variceal bleeding. Endoscopy is now the method of choice for controlling active peptic ulcer-related upper GI bleed. Endoscopic therapy should only be delivered to actively bleeding lesions, non-bleeding visible vessels and, when technically possible, to ulcers with an adherent blood clot, black or red spots, or a clean ulcer base with oozing do not merit endoscopic intervention. Since these lesions have an excellent prognosis without intervention, adrenaline, epinephrine, should not be used as monotherapy for the endoscopic treatment of non-variceal upper GI bleed. For the endoscopic treatment of non-variceal upper GI bleed, one of the following should be used. 1. A mechanical method, clips, with or without adrenaline, epinephrine. 2. Thermal coagulation with adrenaline, epinephrine. 3. Fibrin or thrombin with adrenaline, epinephrine. Interventional radiology should be offered to unstable patients who rebleed after endoscopic treatment. Refer urgently for surgery if interventional radiology is not immediately available. Indications for surgery. 1. Persistent hypotension. 2. Failure of medical treatment or endoscopic homeostasis. 3. Coexisting condition, perforation, obstruction, malignancy. 4. Transfusion requirement, 4 units in 24 hours. 5. Recurrent hospitalizations, types of operations. The choice of operation depends on the site and the bleeding lesions. 1. Duodenal ulcers are treated by underrunning with or without biliroplasty. 2. Gastric ulcers treated by underrunning, take a biopsy to exclude carcinoma. 3. Local excision or partial gastrectomy will be required. Complications can arise from treatments administered, for example, endoscopy. 1. Aspiration pneumonia. 2. Perforation. 3. Complications from coagulation. Laser treatments. Surgery. 1. ILS. 2. Sepsis. 3. Wound problems. Prevention. The most important factor to consider is treatment for H. pylori infection. First-line therapy PPI, omeprazole, lansoprazole, pantoprazole, plus 2 of these 3 antibiotics, clarithromycin, amoxicillin, metronidazole. Second-line therapy, PPI, bismuth, metronidazole, tetracycline, for 7 days.